So good evening, everyone. Welcome to the eMedica National VTS Session 7, the GP Trainee Teaching, open to anyone in any deanery. So we're going to cover some AKT revision. We're going to look at an update to the RCA mandatory cases that recently came up, just some clarifications. And we're going to look at how to write SMART PDPs, both for any rotation, but also once you're a qualified GP as part of appraisal. I just had my appraisal a couple of weeks ago. You know, I set my PDP for the next year. I've been doing that every year since I qualified as a GP. So we're going to look at skills that will help you in training and outside of training. So for those that haven't met me before, my name is Muhibur Rahman. I'm a portfolio GP, which means I've got a variety of clinical and non-clinical roles. Mostly my non-clinical roles are in medical education. And my clinical roles, I'm a partner in my own practice. I was in clinic this morning at a secure unit for women with significant mental health. And as the medical director of eMedica, my main job now is teaching doctors at various stages of training. So the format, we normally cover 3 topics. So AKT, then something to do with RCA or consultation skills, and then something either to do with careers or GP training, skills and things like that. So we'll start with AKT. Because the AKT exam is a week away for January, and I know a lot of you are preparing for that. Today, actually, I'm going to focus a bit more on AKT. We're going to do 5 AKT questions rather than normally we do 3 or 4. And in terms of consultation skills, I'm going to really shorten that bit. We will touch on the update on the RCA, but because I'm going to spend a bit more time on AKT, I'm going to do slightly less on consultation skills, and then we're going to cover how to write SMART PDPs in the last session. So AKT, we're going to do 5 questions. I'll show you the question for 57 seconds. Then you'll see the poll launched. Use the poll to answer. Here we go. First question starting now. So we can see that most people picked D. After that, the most popular answer was C. So 50% was the most popular, followed by 25%. So in any picture test, look at both the picture and the scenario. So if you look at the picture, what we're seeing here is mum's affected, okay? And then on that side, looks like the grandfather's affected. On the other side, dad's not affected, neither are the paternal grandparents, neither of them are affected. So what's their risk, okay? The patient's risk here is what we're trying to work out. So now, if you didn't know the way that Huntington's is inherited, you could probably work it out from this picture. So what's the inheritance of Huntington's? Type that into the chat. I'll put that back into public mode. So yeah, absolutely right. Huntington's is autosomal dominant. So what that means is you only need one faulty gene to have full-blown disease. So if mum's got it and dad hasn't, what's his patient's risk? It's 50%. Okay, so D is the right answer, and well done. 3/4 of you got that right. Okay, but that means 1/4 of you didn't quite get it right. So let's look at why that might be. The first thing is that you might not get it right because you didn't know that Huntington's is dominant. And so if you didn't know that, this is where the picture would help you, that you could sort of work it out that, look, if the grandparent here had it, but the grandmother didn't, but the children to get it, any of them, it has to be a dominant condition. If it was recessive, grandmother would at least have to be a carrier, wouldn't they? Okay, and so that's going to help you. In a dominant condition, if one parent's got it and one hasn't, the risk is 50-50, okay, that you're going to have full-blown disease. So 50% is the risk. Okay, so autosomal dominant, 50% risk if one parent is affected. Now, what are some other autosomal dominant conditions? Type them into the chat. So Huntington's is one we've just covered. What are some of the other autosomal dominant conditions? Okay, so people have put Marfan, achondroplasia, polycystic kidney, Duchenne's, and Duchenne's isn't. It's not autosomal dominant. Neurofibromatosis, yeah, great. Ehlers-Danlos, people have put, Poitz-Jaeger, various others. Okay, great. So probably some of the most important, I mean, there's a whole list, right, of things that are autosomal dominant. You know, there's loads of them. But if we think about some of the most important ones for you to know for the exams, some of you have got a lot of these. So Marfan, achondroplasia, neurofibromatosis, then Huntington's are probably some of the most important ones. You know, if you type it into Google, you see on Wikipedia, there's probably 170 different autosomal dominant conditions. You know, a lot of them though are very, very rare. And if we look at autosomal recessive, some of the more important ones, things like cystic fibrosis and PKU, which we screen for as part of the newborn screening program in the UK. Sickle cell is another autosomal recessive condition. Someone has said Duchenne's. Duchenne's is X-linked recessive. Duchenne's muscular dystrophy is X-linked recessive, as well as Hunter syndrome and color blindness. And X-linked dominant, things like Fragile X, Allport or Rett syndrome is another one. Polygenic, so that means there's multiple genes. It's a bit more complex. Things like pyloric stenosis, neural tube defects, and then you've got the chromosomal disorders. So things like the trisomies. Trisomy 21 Downs, you've got Edwards, Patau, you've got Turner's 45XO, you've got Klinefelter's 47XXY. These are the chromosomal disorders. Okay, good. So let's move on to the next question. Now, every single AKT has to have, it's in the regulations, at least one, and usually has at least two drug calculation questions. One tends to be a pediatric one tends to be a cancer-related one. So let's do a peds one. Okay. Calculators are allowed, just like the exam. So again, 77% of you, so you know, just over 3/4 of you have picked D. The most popular answer after that is A. Okay, so 11% picked 2 mils QDS, and then 8 mils QDS is the most popular answer. After that, we've got 32 mils QDS, so 5% picked that. So let's look at the correct answer. So the correct answer is D. Now, before I go on to do the calculation with you, just let me know in the chat, and I'll put it back on. Is there anybody that actually thought it was D, but because the last answer was D, you didn't want to put 2 Ds in a row, and you actually changed your mind, not because of the calculation, but just you thought, oh, there's a pattern, and I don't, you know, I think they're trying to get me here. And so you actually changed it because of that, because it actually happens in the exam sometimes, especially with extended matching questions where there's a set. And sometimes in an EMQ, the same answer option is the right answer for all 3 in the set. And some doctors, you know, they just don't want to put 3 in a row because they think that there's some kind of pattern here. It wouldn't be like that. That seems too easy. It's really important. You mark each question based on what the answer is, not based on what you think they want you to put, or in terms of, you know, that someone's trying to get you or a pattern, because that's not the case. Okay, so let's do the calculation. So the first step is that this child weighs 16 kilograms, and the dose, this is the dose from the BNFC. They'll always use the actual dosing in the exam. Okay, 25 milligrams per kilogram QDS is the dose to give. Okay, now if they're 16 kilograms and it's 25 milligrams per kilogram QDS, they need 16 times 25, which is 400 milligrams QDS. Okay, now the concentration of flucloxacillin as a liquid is 250 milligrams per 5 mils for this age group. Again, that's based on BNF. So if there's 250 milligrams in 5 mils, if you do 250 divided by 5, there's going to be 50 milligrams in every 1 mil. So if we want to give 400 milligrams, but we're going to give it as a solution, as a liquid, then we need to do 400 milligrams divided by 50, which gives us the dosage, which is 8 milliliters QDS. So, you know, I'm really happy to see that most of you got it right. For those of you got it wrong, a couple of common mistakes. So those that picked 2 mils QDS, now do you see, underdosing this child by a factor of 4, they're not going to respond, and they may become systemically unwell and septic. So that's dangerous, okay? Equally, someone that gave 32 mils QDS, that's 4 times the dose, and that could be harmful for a 4-year-old child. So 2 things I would recommend you do. One is read really carefully. So it's 25 milligrams per kilogram QDS. All these doses are QDS, okay? So then you can ignore the QDS. All you need to worry about is 25 milligrams times 16, 250 divided by 5, and then just do this math. The QDS, you can, because it basically cancels out, right? That bit there, and they're all QDS dosings in the answers. So we can forget that. Whereas otherwise, what some of you have done, you've then divided this answer by 4, and that's how you've got this. Some of you have multiplied by 4. The other thing I would say is just do a reality check, okay? Because they will always use the actual dosing of drugs in the real BNFC in the exam. Just think about 32 milliliters QDS. 32 milliliters is 6 and a bit of the big end of the spoon. Or if you're using a syringe, you know, those 5 mil syringes that sometimes come with pediatric drugs, okay? You know, that 6 syringes worth of medication is 30 mils because it's 5 mils at a time. And then you're given a bit more. Are you really going to give that to a 4-year-old child? Especially, I don't know if any of you have ever tried to give flucloxacillin. It is really, really disgusting, okay? You know, children will drink down amoxicillin. They love it. But flucloxacillin tastes really foul, right? I don't know why they can't make flucloxacillin amoxicillin flavored, because that tastes banana flavor. It's nice. Okay, but just do that little reality check. Like similarly, sometimes you'll do a cancer pain one, and you calculate a dose of morphine, and you know it's a 85-year-old lady, and they're opioid naive, i.e. they're first going on to morphines, you know, with this cancer, and you do a miscalculation, and instead of, you know, something like 40 milligrams as a starting dose, you've calculated 400. Just say 400 milligrams of morphine. You know, that sounds like a really big amount, doesn't it? That is probably way too much as a starting dose. And so just do a little reality check, because they'll use the actual dosing, but they will put in the common mistakes, because the common mistake would be to take this and then multiply by 4 or divide by 4. So they'll put that in, okay? Right. Question number 3. Here we go. Good. So I can see that I've closed up all. I'll put the chat back on. And this one, much bigger spread. So the main spread is between A and E. Okay, so A and E. So E was 40% of you, A is a third of you, and then C and D after that. Okay, C and D. Now, this is what I call a 2-step question. Okay, the answer is about management, which is the second step. That's what's going to get you the mark right. The first step is working out the likely diagnosis, because that's going to make the answer much easier. So you could get this question and they could list a series of diagnoses here, and that could be the question, right? So just type into the chat, what do you think is the likely diagnosis based on, now I picked this because we know that dermatology is an area people struggle with, but in the last examiner's report, they highlighted that, you know, questions with photos, people often do poorly on. So remember, it's important to look at both the picture and the scenario in a picture test if you want to get it right. So just type into the chat, what do you think the diagnosis is? Okay, so a few people have said alopecia. That's not enough, okay? There's like 7 different types of alopecia, okay, that are common. There's 9, you know, including some of the ones that are a bit less common. So we've got to narrow it down more than alopecia, all right? We know it's alopecia from the title, that it's hair loss, right? So which type? Okay, so someone said psoriasis, all right? And some people have said alopecia areata. Those 2 seem to be the main sort of things that people have picked. Okay, and just see if anyone else has put androgenetic alopecia. Okay, good. So they're really the main ones. And someone else has said tinea capitis. Okay, right. Okay, good. So the correct answer as to what the diagnosis is this is alopecia areata. Okay, not androgenetic alopecia. It's alopecia areata. Now, I can see why some of you have thought about psoriasis, maybe because of the pitting of the fingernails. But if you actually look at the scalp, there's no scale there. All right, there's no plaque, and so that doesn't fit quite as much. What does fit, especially with the tingling, is alopecia areata. So now that makes it a little bit easier. What's the right way to manage that? Okay, now if I just look at what people picked in the poll, actually. So yeah, okay. So the correct answer for that is a potent steroid. So which of these is a potent steroid? The correct answer is E. Betamethasone valerate is a potent steroid. Even though this concentration is much smaller than this, hydrocortisone on its own is a mild steroid, and so it's not suitable for treating this. Okay. Hydrocortisone butyrate is a potent steroid. It's the butyrate compound that turns it into a potent steroid. But hydrocortisone on its own, whether it's 1%, 2.5%, 0.1%, it's a mild steroid in terms of potency. Betamethasone valerate is one of several potent steroids that you could use for this if the patient wants treatment. Because if there's some signs of regrowth and the patient isn't sort of, really keen to have treatment, you could just leave it alone and see if it starts improving. Okay, especially if it's not huge patches. Okay, so there's no indication for referring to dermatology at this stage. If you tried this and it didn't work, or if it was more widespread and you weren't sure what the diagnosis was, then you might refer to dermatology, but at this stage it's not indicated. Finasteride can be used for androgenetic alopecia in men only, and minoxidil can be used for androgenetic alopecia in women or in men. You can't use finasteride for women. Both minoxidil and finasteride are only available either privately, or you can buy minoxidil over the counter. Neither are available on an NHS prescription. Okay, so just show you some of the differences between alopecia areata and androgenetic alopecia. Both of them cause patchy hair loss, but in alopecia areata, it's normally very well defined, and it's either a circle or an oval, and often there'll be more than one patch. It typically affects the scalp and the beard. Okay, and then androgenetic alopecia, often, again, it's patchy, but it's not as well circumscribed. You can see there's a patch of loss here. It's not loss all over. It's patchy, but without such a well circumscribed margin. And then the other thing is that often it will be at the top, or like the top and the back, or around the sides, and a slightly different pattern in men compared to women. Okay. So alopecia areata is a chronic inflammatory condition. It causes a non-scarring type alopecia. Usually there's quite a rapid onset, and most commonly it will affect the scalp or the beard. And you see either circular or oval type patches, but they tend to be well circumscribed. Okay. In a lot of cases, there's no symptoms apart from the hair loss, but sometimes there'll be tingling, sometimes there'll be itching. The scalp itself, though, tends not to have scale or anything like that. Okay. So even if there's itch, there's not like plaques like there would be in psoriasis. And then you do often get other changes. So things like nail pitting, you can also get, okay, or leukonychia, so white bits on the nails, you can also get with alopecia areata. And where treatment's required, a potent steroid is first line. So there's a couple of options here that you could use as a potent steroid to put on topically. Okay, so it's like a foam or a liquid type thing that you put on. Okay, right, stats. Okay, that's fine. So I can see that most people pick D, followed by sort of the others are all a lot less popular, but nearly 80% of you have picked D. Okay, so this is, anyone know what type of graph this is? Let me know in the chat if you know the name of this graph. Not what it's looking for, what's the name of this type of graph? Anyone know? Or a very specific name. So this is called a regression analysis. Okay, this type of graph is called a regression analysis, and this is a linear regression. This line here is a linear regression. Okay, if we didn't plot this line, then it would be a scatter plot. So this isn't a scatter plot anymore. It was a scatter plot. Before we calculated the line, it was started out as a scatter plot. But once we calculate the line, that line is called a linear regression. The graph becomes called a regression analysis. Okay, so what can we tell from it? So the correct answer is D, that there's a positive correlation between emergency admission rates and proportion of patients age 65 plus. If you look here, on this axis, what we're seeing is number of emergency admissions with cancer per 100,000. That's what this question was about, right? Okay. If we look on this side, we've got percentage of patients age 65 plus. All right. This isn't the age of patients. So, for example, we can see A and B, patients age over 20 have the highest rates. We can't say that because we don't know. We have no data about any patients under the age of 65 from here as to what happens to them. So we can't guess that from the data. That might be true, that patients over 20 have the highest rates, but we can't say that from the data, which is what the question is asking. Equally, patients under 10 have the lowest rates. That's probably true, but we can't tell that from this data. We have no data about anyone under the age of 65 here. We're just looking at the percentage of patients age 65 plus and how the rate of emergency admission relates to that. You see, so that's the first thing, is reading carefully and interpreting the right data. So that's why A and B are incorrect. Now, if there was no correlation, then really you'd see no pattern. Okay, for correlation, imagine the line isn't there first of all, and if you can't see any pattern, there's no correlation. If it just looks random, you can see that roughly, like we've calculated the line, so it makes it really easy. This line goes upwards, so it's positive. If it went downwards, it would be negative. Okay, if you couldn't really fit a line because there was just random all over, there'd be no correlation. And so that's why D is the right answer. That is positive because it's going upwards from left to right, i.e., as the percentage of patients age 65 goes up, the number of admissions goes up. That's what positive correlation means. Negative correlation would be as one goes up, the other goes down. Okay, so this is what a scatter plot looks like. But you see, this started life as a scatter plot, not a scatter plot anymore. So a scatter plot, each of these points is one point of data. Can you see it looks like I've scattered these onto the graph. Okay, so imagine now there's no line, but we can imagine a line would fit nicely here, wouldn't it? So if the trend looks from left to right upwards, it's positive. If it's downwards, it's negative. Okay, so look, this is negative because it's downwards. This is positive because it's up. This is negative because it's down. Then if the dots are tightly packed together, there's a strong correlation. Strong or high. If they're a bit loose, low is loose. And then can see this is what no correlation looks like. You can't fit one nice line through here. There's just no pattern. Now, if we calculate the line that best fits through these dots, like we've done in this one, this is a different graph. Then can see the line itself is called a linear regression, but this graph is now known as a regression analysis. Again, now if we look at the slope from left to right, if it goes upwards, it's a positive correlation. If it goes down, it's a negative correlation. The steeper the slope, the stronger the correlation. And then one of the things you can do then is you can calculate for any value across here, the x-axis, you can calculate the value on the y-axis. What you can't do is extrapolate beyond. So for example, here, let's say this was age, and let's say this was number of admissions or whatever it was, okay? You could say, okay, at age 3, you're likely to have had this many admissions in total. You know, maybe children with asthma, for example, okay? By age 4, you're likely to have had this many. What you couldn't say is, at age 8, you're likely to have had 15. We have no data on age 8, so you can't go beyond the limits of what's there. But within here, there might not be a child that was 1.5, no data, but you could extrapolate by drawing a line there and working out what it's likely to be. Okay, someone's asked a good question. In here, what's this black dot? So we've got no key here, but usually what this would be is each of these would be one data point, and this would be a sort of marker that you're comparing to. So for example, this actual data is pulled from Public Health England. Each of these is the data for this information for one CCG, Clinical Commissioning Group. And this diamond in the middle is the England average. Okay, last one, clinical governance. Now in the exam, you'd be dragging and dropping these into the right box to answer. I'll just show you the answer because I can't make you drag and drop. Okay, so have a look at this. I'll turn the chat off. There'll be no poll. I'll turn the chat back on and ask you after 55 seconds. Okay, feel free to write your answers into the chat. What would be number 2? What would be number 3? What would be number 4? But in the exam, you'd actually be dragging these. Now, this is a multiple best answer. You have to get them all right to get 1 mark. You get 1 or 2 wrong, you won't get partial marks. You get no marks, unfortunately. Okay, so that's time. So the correct answer, or the correct order, looks like this. Okay, so this is the the clinical audit cycle, right? So you set the standards first. So let's say, for example, all of our patients who have been started on an ACE inhibitor should have a measure of their use and ease within 1 to 2 weeks. So 2 weeks at the latest, that's our target. And we might say, look, we'd like it to be 100%, but we're not going to achieve that. But at least 90% is what we'd like. So that's the standard. Then you measure your current practice. So let's say now in our practice, we're only getting 80% of them are measured. Then we'd compare the results to standard. So we want 90, we've got 80, we're 10% below the standard. Which can you see, if you were way beyond, you might need to look into it more. If you're way above, okay, you're doing really well. Then you reflect, then you plan your change, and then you implement the change. So you might say, okay, what we need to do is how are we going to make sure we don't miss this? Right, let's do 2 things. 1, let's put a little automated reminder that flags up. You can set, in eMIS Web or in System 1, you can set your own flag. So like any patient who's on an ACE inhibitor, that either when you start them or when you change the dose, they should put up a little flag to remind you, give them a blood form for 2 weeks' time or 1 week's time. But then you also set a little thing on the prescription, and again, you can automate this, that anyone that's prescribed an ACE inhibitor, just for it to print a reminder for the patient to say, have you had your blood checked, okay, to check your kidney function. And so they might, remind you, okay? So, as an example, then do your change, then re-audit, and then you do it again, right? So that's the complete audit cycle. So you'd need the whole order right, and you'd be dragging them into place, okay? But you need the whole thing right to get 1 mark. If you got even 1 in the wrong place, you'd get no marks, okay? So just to recap again, for those of you that are sitting the exam very soon, we've got lots of free support for AKT. So, I've been posting the 30-day challenge videos in both the AKT support group and the GP training support group. So that will continue up until day 30. These webinars, the ones that we do every month, and then we did in the first lockdown 1, we did the lockdown learning series. We're doing those regularly. All of those, the first section is always AKT. Then we do communication and consultation skills. Then we do careers or GP training. So you can go back and watch those. There's like 18 hours worth of videos now on our YouTube channel, covering these, because we've done 7. This is the 7th one of these. We did 9 of those. And then for those of you that missed our recent high yield masterclass webinars, if you want to cover a lot of ground in a short amount of time, this close to the exam, this is exactly what you want. And it's learning like this, where we do a question to time, then we, go through the teaching and the relevant guidance. So we did stats last Tuesday, 46 questions like this, but more than 60 key stats topics. There's a detailed PDF, all the key stats that you need basically to do really well with worked examples. Admin, 45 questions, again, more than 60 admin topics, all the key admin topics that you need, updated, including the new changes to the essential and additional enhanced services for the GMS contract, changes to notifiable diseases for COVID, and then the clinical, 57 questions, more than 70 clinical topics. All of these topics are topics examiners mentioned in past reports. These topics get tested again and again and again. And so you can either get any one of them or all 3 of them at a discount, or we have that AKT 200 where we do 4 50-question teaching mocks. So we cover 200 high yield topics like this, and then you get a full online mock afterwards with 200 different questions. Okay, so 400 questions in total. We have those as a bundle. So either the masterclass bundle has stats, admin, high yield clinical, so that's already discounted, or the booster bundle, which includes all of that and the AKT 200 and a 200 question mock. And then for those that are sitting the exam going forward, we've got our main AKT course. The next one will be in March, although we are running one for health education east of England in February. So if you're part of that deanery, you might be able to access that. We're running our AKT 200 live next in April with the Royal College. That's just open today for bookings on the Royal College website. And then we've got our structured programs, AKT Pass Plus, 110 hours, 2 full-day courses, 4 webinars, AKT Pass Guarantee, 220 hours, 9 webinars, 2 full-day courses, 3,000 plus questions, everything basically, and structured guided revision. Okay, we've got online revision, and the case cards are out of stock now. They're actually just being updated. So the 2021 version will be out at the beginning of February, up to date as of 2021. So consultation skills and RCA update. So really what I wanted to highlight is the main update to the RCA is the mandatory cases and the sanctions that apply if people submit their RCA missing any mandatory cases. And there were a lot of questions previously when they announced the mandatory cases as to which type of case could go into certain categories or not. And they've clarified that now. So I wanted to make sure you're all up to date. So these are the mandatory cases. If you submit your RCA, your 13 cases, and any one of these is missing, you will lose 18 marks from your total score. If you submit and any 2 are missing, you will automatically fail the whole exam, regardless of how well you did in your other videos. Okay, you just fail automatically. So it's really important you don't miss any mandatory cases, because losing 18 marks for a lot of doctors will be the difference between pass and fail anyway. So the mandatory cases, you must have one case that's a child, so 16 or under. You must have one case. Now, in some cases, the child case might not be a child on the video or the telephone. It might be, if it's a young child, if it's a teenager, it might be them, right? But if it's a young child, it might be, for example, the parents talking to you, I think my son might have ADHD. I'm worried because of the way he's been behaving. That could be your child case, because it's about the child, okay? One has to be an elderly patient over 65 years old. One has to be a mental health condition. The reason that they've come to see you, the main reason for that consultation is to do with mental health. And so, it could be any mental health condition according to the DSM or ICD criteria, but it's got to be that's what it's about. It's about depression, it's about anxiety, it's about post-traumatic stress disorder, it's about someone with psychotic symptoms, or someone who's got mania, or any mental health condition. But that's what the consultation is about. What wouldn't count is, imagine someone who happens to have depression, but they've come to see you today to get a repeat prescription of the pill, and their mood isn't an issue or related, it's incidental, they just happen to have depression. Okay, this consultation is actually about the pill. Now, if you labeled that as mental health and didn't have another mental health case, you would get 0 marks for that case. Okay, maternal and reproductive health, one of them's got to be that. Now, a lot of people ask, what does that include? Is it just to do with obstetrics? No, it's much broader than that. It could include sexual health. It could be, someone with a potential STI. It could be a male with erectile dysfunction. It could be a lady with talking to you about contraception or HRT, or someone struggling to get pregnant, infertility. It could be someone with a possible ectopic. It could be any of these things. It's very broad. Okay, one's got to be a long-term condition. So that's an existing diagnosis of a chronic condition. That could be a cancer, someone with diabetes that's poorly controlled, a disability, multimorbidity, different illnesses. What that doesn't include is someone that might have one of these diagnoses and you don't know if they've got it yet. That's not what long-term condition means, okay? Someone who's got an established diagnosis of it. If you see someone and you think, this might be prostate cancer, I'm going to do 2 weeks. That's not a long-term condition, because it might not be. All right, it might not be that. All right, so it needs to be something where there's an existing diagnosis of a long-term problem, whereas something that needs to be seen within 2 weeks would fit into acute problem, because that was another one that a lot of people asked for clarification. Does that only include someone who has to be admitted? Because the wording was like this: acute problem needing urgent investigation or referral. So now they've clarified that would include anyone that needs to be admitted or seen within 2 weeks. So a suspected cancer could fit into an acute problem because of an urgent referral. An urgent referral means within 2 weeks, right? Or anything more urgent than that. So an admission, or someone that needs to be seen within 24 hours, like someone with a TIA symptoms, they're going to need to be seen if they had the symptoms a couple of days ago within 24 hours. That would fit, okay? Someone with a stroke that you're admitting directly, that would fit. Okay, someone with an acute coronary syndrome, that's an acute problem, you're going to admit them, that would fit, okay? And then you need at least 2 cases where clinical examination is needed for that case. It does not mean you have to do the examination on the tape, because if you're doing telephone one, it might be explaining that in order to work out exactly what this is, we would need to examine this, this, and this. So we'd like you to come in. If we find this, we might do this. If we find that, we might do that. That still is a case that requires examination, Doesn't mean you have to physically do it on the tape. And if you're doing a face-to-face, any intimate examinations mustn't be on the video. You should do that behind the curtain. Keep the video running because the time still counts. But what you mustn't do is actually film the patient with their top off or their bottoms down. Okay. Now, in terms of mandatory cases, one case can hit more than one of these areas. You still need 13 different cases, but you can hit more than one mandatory case with one case. I'll give you an example. You've got a 14-year-old boy comes in with severe unilateral pain in the scrotum, and you think he might have testicular torsion. See, that ticks the box of child under 16 or 16 or under, ticks the box of acute problem because he's going to need an admission, and it ticks the box of requiring clinical examination because you're definitely going to need to examine that. You've ticked 3 things with that one case. Okay, you still need to submit 12 more cases, but you don't then need to find another case as an acute problem because you've got an acute problem. Okay, so that's the main thing I want to update you about in terms of RCA. The other thing a lot of people have contacted or asked in the group about is, when will we know if RCA will continue beyond the current date that's listed as the last date is May. When we will know if RCA will continue for the rest of this year or whether CSA will come back. So the Royal College has said that they will give at least 6 months notice. So it's likely we'll know in February, maybe March at the latest. Okay, great. And in terms of RCA, if you want support for that, we do have a recording of our masterclass webinar. We do have our RCA course. So we were running that yesterday, actually. Where we have 9 doctors, we have a male simulator, a female simulator, myself, and then we have another assessor. So you get detailed individual feedback, lots of practice, small group, but with professional simulators. So you get a real feel of what it's like and detailed individual feedback. So there might be one slot in one of the February days because I know someone needed to swap to March. So have a look on the website. Someone will post a link, okay? And watch out for our new bundle with the masterclass and some one-to-one coaching sessions that's coming up, okay? So I want to talk about personal development plans now, all right? And when you're in training for each rotation, you need to think about a personal development plan. But similarly, when you're qualified, and a lot of you are now in your last year, you're going to be qualified, and some of you are already qualified. As part of appraisal, every year, I write myself a PDP. I normally put 3 things in it. Okay, so the idea is to assess your own learning needs and put in a plan to act on that to try to help you to make improvements. So what you want to have is a learning objective. That's like the main part of your personal development plan is what is it that you want to learn, and then you have a target date and then an action plan as to how you want to achieve it. Okay, and how will you know it's achieved? So a good personal development plan should be SMART. So what does that mean? Okay, it should be specific, it should be measurable, it should be achievable, it should be realistic, and it should be time bound. So we're going to do a short exercise just for 3 minutes, okay, or 2 minutes, okay. That's all the time it takes, to be honest, to do a really quick one, and then you flesh it out a little bit. Because sometimes people contact me and say, what should I put in my PDP for XYZ? No one else can write a PDP for you because it's a personal development plan, all right? So it needs to be personal to you. Why? Because your learning needs might be very different to mine, might be very different to a different colleague doing the exact same rotation. So it's really important that you think about and use this as a learning tool. Don't just put something down to tick a box. You should use it as an opportunity to help you improve and be a better GP at the end of it. So I'd like you all to think about the very next rotation that you're doing. And those of you that are going to start in February, if you know your first rotation, just write down, just pick one thing to put in your PDP. Typically you put 3, 4, 5, okay? I do 3 each year, but just write down one item for your PDP that's specific, that's measurable, that's achievable, that's realistic, that's time bound, okay? So just spend a minute or 2 doing that. And then feel free to just write it down at home. If you can't type that fast, if you want to type it into the chat, feel free to type it into the chat. And then I'll show you an example of one. Tell you what, while people are doing that, let's give an example. Okay, so here's an example. Right? Let's say somebody felt that they're not really confident in HRT, and maybe they're in a GP rotation. They're seeing a lot of women coming to see them and asking for HRT, and they're really not confident because they've never done a women's health rotation in hospital, and they've just started in GP. They've not been in GP before. They just haven't come across lots of people asking for this because it's not an acute problem that you see in hospital. So the first thing is that what their learning objective is that they'd like to improve their knowledge and confidence of HRT, right? So, you want to make it specific. So look, here's an example of something vague. Learn women's health. It's too vague. Here's something specific. I'd like to improve my knowledge of HRT options, okay? So then make it measurable, right? So how am I going to do that? I'm going to complete some CPD, and then I'm going to pass the assessment in the post, like let's say you do a learning module, there might be an assessment at the end. Rather than something vague that I'll be able to handle HRT better. See, that's really vague, all right? Make it achievable. So you might say, okay, my plan is I'm going to do an e-learning module, and let's say you've identified one, like there's one on e-learning for health that I did. It's really good, okay? In fact, there's a couple. And so maybe that's 2 hours CPD, or maybe you found there's a 1-day course, a women's health update on HRT, for example, or maybe, a webinar. Whereas what's not achievable is for you to say, to learn this during GP training, while I'm also going to prepare for membership, I'm going to do an MSc. That's not achievable, is it? It's not realistic for you to do that during training. And then are realistic and relevant, all right? So, think about your timescales, think about your workload, think about what's relevant to you developing as a GP. And finally, time bound. You set a date by which you should achieve it, rather than at some point in the future, I will be better at this, okay? So, that would be vague, right? Okay, so, that's how you make. And what you could do is, if you're not sure the rotation you're going to go to, get the Royal College curriculum, have a look at all of the learning things that they expect you to have learned by the end of, about that subject in the GP curriculum that's relevant to your rotation. And think for yourself, like some of you might already know lots about HRT. So for you, this wouldn't be a good PDP. For you, it might be actually Menareja's your weak area. Do you see that's specific? And then again, you could think about how you're going to achieve that. What's not good as your starting point as a learning objective, if we go back to here, okay, is to say something like, go to clinic. Going to some clinics might be something, some of the ways you're going to achieve it. I'm going to attend 3 clinics using my half day for a 3-week period, and then I'm going to do an e-learning module, and by then I'm going to do this, okay? Do you see what I mean? Okay, that might be part of how you're going to achieve it, but as the actual learning objective, going to clinic, that's not an achievement, is it? That's not a learning objective. Your learning objective is to improve knowledge of this thing, or be more able to manage these conditions, okay? So that's, I use that same framework. You could use that for any rotation, but I use that same framework, exact framework, for my appraisals, and I have been doing for the 13 years of appraisal I've done since I finished GP training, okay? I did my 13th one a couple of weeks ago, last month I think it was. Okay, so, that same framework makes it really easy for you to write your own PDPs that are going to be a good learning tool for you, and that are specific for any rotation that you could do, okay? Those of you that are starting training soon, welcome to GP. You might find helpful our GPST Plus course on how to maximize your training. This session we did is one small part of the workplace-based assessment, which is one of the 3 components of MRCGP that we covered. You'll see that it's from this course, GPST Plus Maximize Your GP Training. Someone will post a link to that, okay? So I'll just take questions now for the last 5 minutes, and then I'll let you all get away, and I'm going to go and have some dinner, okay? Someone's asked, are the reference ranges included in the exam? They will be for things that are rare and obscure. So for example, if they gave you an FSH-LH ratio, they're probably going to give you a reference range. For common bloods, they often won't give it to you. So if there's an FBC, or if there's a HbA1c or a fasting glucose, knowing what the level is to diagnose, that's part of the test. They're not going to give you that. Or if they give you someone's U's and E's, they'll expect you to be able to interpret that without necessarily the reference range. Or is this a microcytic or macrocytic anemia? They're not going to necessarily give you the reference range for that. They'd expect you to know that. So it's worth learning that. Okay. Someone asks, what happens if you manage to complete what you wanted to achieve, or go back to SMART after the date? That's fine. Then you put an entry as to why you couldn't achieve it, or why you achieved it after, and that can be part of your reflection. It's another learning log for you. For example, last year I couldn't achieve 2 out of my 3 PDPs because what? Because COVID happened, the pandemic happened. Sometimes things happen, right? Okay, so you could make that, actually gives you another learning log entry as to a reflection as to why you couldn't do it. Okay. Someone's asked, any advice on how to use the last week before the AKT? It's a great question. What I would recommend you do the last week before the AKT, recap all the key stats, okay? Recap all the high yield admin topics, recap the high yield clinical topics, recap all of the topics in our high yield AKT checklist, okay? Which is all the topics the examiners mentioned from the last 10 years, and then just do some mocks. That's what I would recommend you do in this last 10 days. That's going to give you the maximum increase in your marks for the time that you've got. Why? Because admin stats, while they're 20% of the exam combined, 10% admin, 10% stats, If you learn them well, there's only so many things that come up. I've seen lots of people get 80, 85, 90, 95, 100 in stats and admin. It's going to help you get away with 70 in clinical. Clinical's huge. So by this stage, you should have covered the bulk of topics. If you haven't, you're not going to be able to cover everything in a week. What you can do in a week is at least cover all the high yield ones, the ones that come up most often, or that examiners have mentioned as problem areas. So you could do that through these webinars or through the AKT 200 or the booster bundle, which includes all of those. Okay. Someone's asked, do you have an example study timetable? If you want a structured program, then what you would benefit from is to join one of our structured programs. Okay. So the most structured program we have is our pass guarantee program. Okay, so I'll just show you. If you go to our website, AKT, these are our structured programs. The pass guarantee, 220 hours over either 90 days or 150 days, or the pass plus bundle, which is 110 hours. Okay, this one, there's 2 full-day courses, 9 webinars, but on top of that, there's 90 daily guided revision emails. So if you do the 90-day program, every day we send you an email and we'll tell you, read this nice guideline, do these questions. Okay, the next day you have to have finished that by within 24 hours. The next day, read this, do this question of the day, read this topic, do this. Then we have webinars, we build on exam technique. Then we have the full day courses. Throughout all of this, you'll also be doing questions every day. Some are from us, some are from the Royal College. We'll do various mocks. We'll collect data about which areas you need more work on. We'll send you an individualized plan for the last 30 days, different for everyone. By the end of it, you will have covered all of the key things in the curriculum. You'll have done over 3,000 questions. You will have done 3 full mocks plus a full mock on a talk basis at the 200 crammer course. You will have read the revision cards. You will have read things from the Oxford Handbook of General Practice. You will have had tailored revision. So you have a program laid out for you day by day for either 90 days or 150 days. Okay, so that's our most structured program. So again, if that's what you're looking for, because a lot of people like that you don't have to think then. You don't have to spend any time planning. All you have to do is do the work. We just send you it. Do this, you just do it. That's it. Okay. So that's our next program is the April program. The 150-day program already started. We, 30 days into that or whatever. The 90-day program is starting at the end of this month, the 28th, I think. Let me see the dates. All the dates are here, by the way. Okay. So yeah, the 90-day will start on the 28th of January. And then these are all the different things. And then every day for 90 days, you'll be sent an email with work. If you're not a member of the GP Training Support Group, do join. If you're not already subscribed to our YouTube channel, do subscribe to get updates on the videos. Let us know what you thought and what you'd like for next month. And then a huge thank you to everyone that joined. I hope to see you next month. Okay. Those of you on the pass guarantee, I'll see you the night before the exam for our last webinar. Keep pushing, keep up your hard work, prepare, and you will succeed. Thank you very much, everyone. I'll see you next month.